Welcome to Breakthroughs. I'm Erin Spain, host of this show. We're thrilled to be back from a summer hiatus to talk about discoveries and breakthroughs from our scientists at Northwestern University Feinberg School of Medicine. One of our physician scientists who's been extremely busy in 2020 is Dr. Michael Ison. He's part of Northwestern research teams running studies on both COVID-19 and on influenza vaccines and treatments. As flu season begins and COVID-19 continues to spread, Dr. Ison is here to share some of his latest findings. He's a professor of medicine in the Division of Infectious Diseases and of surgery in the Division of Organ Transplantation. He's also the director of NUCAT's Northwestern University Clinical and Translational Sciences Institute's Center for Clinical Research. Thank you so much for being here today, Dr. Ison.
Thanks. It's an honor to be here with you.
What have the past 200 days or so been like for you since the COVID-19 pandemic began?
Yeah, I think that the thing that kind of amazes me is it's been a very different year for everyone, including myself. When COVID-19 first really started to emerge in the United States, a lot of the initial focus was getting the clinical side of our operation in place and helping the various teams with advice and care of the sick patients that we were seeing that no one had experience with. That quickly pivoted into efforts to collect specimens so that we could study patients with COVID-19 and really gain a better understanding of what was working and what wasn't working in these patients. Then I was asked by the NIH to help chair the Data Safety Monitoring Board for their big trial focused on therapy for COVID-19 called the Adaptive COVID-19 Clinical Trial, or ACT. This study has really been very helpful in defining some therapies that are now standard of care, like remdesivir, for us. It was originally thought to be a really short involvement in a study that was only going to be involving a small number of study sites. Very quickly, it expanded and still is going on, and so an appointment that is continuing. Over the summer, as the numbers started coming down, we got busy again pivoting to the focus of patients that had recovered from COVID-19 and really trying to collect specimens so that we could understand what were things that were different in these patients and what were their antibody responses and how long did they persist. And that's been continuing on since then. And now we're getting repositioned to kind of again start enrolling patients in studies that we have up and running, including studies of new therapies, vaccines for COVID-19, and then again begin collecting specimens in patients that are sick with COVID-19. One thing that I didn't get very much of was time away. Vacation, I think, like a lot of people, has been very different than in prior years. Normally, I would be traveling around the country or out of the country for a relaxing vacation. This year, it was really quick trips to relaxing places along the coastline in Wisconsin and Michigan, and not really much further afield than that.
You've certainly been involved in many different aspects of studying COVID-19, as you just mentioned, but what do we know now that we didn't know at the start of the pandemic? It seems like every week we're learning something new or something more about this virus.
I think we've learned a lot, not only about the virus, but how we can protect ourselves and keep people from getting very sick or dying. We've learned a lot. If you recall back when we first started our advice around COVID-19, there was confusion about whether masks should be worn or not. I think we have really strong evidence now that masks and social distancing is incredibly critical in controlling the transmission of the virus. We've learned a lot that is very different with this virus than other viruses. The host immune response is very important to the clinical disease that we see with COVID-19. And so that's had us focusing not just on drugs that help slow the virus replication, but also reduce the amount of inflammation that is triggered by the virus itself. And then lastly, we've learned a lot about how we can function as a society. We have to still be very thoughtful and careful, but we've learned ways to open up our businesses and our societies so that we can maintain people as healthy while having some commerce go on, although still not the same as it was a year ago.
Yeah, Chicago looks a little different right now with all the restaurants that have spilled out into the streets so we can enjoy outdoor dining. People have been really creative with this.
Yeah, and I think we're going to see continued creativity as we get into the cooler months where we won't be able to sit outside.
Right.
So I think creativity is going to be the key to success for a lot of things moving forward.
Well, speaking of the changing of seasons, we are recording this episode during the first full week of October amidst a flurry of COVID-19 news. President Donald Trump has been infected with the virus and is receiving treatments as we speak. What sort of treatments is he receiving, and what's your assessment of his situation based on what we know?
So whenever you're not actually caring for patients, it's very hard to really make an assessment of how the patient is doing or what choices the team that's caring for him is making. But what we do know is that he's gotten at least three therapies that are recognized to be active against COVID-19. Initially, he got something called a monoclonal antibody. This is an antibody that's produced basically in the test tube that helps bind to the virus and prevent it from replicating. Most of the limited studies that we have of this group of drugs really suggest that early treatment like he got may be beneficial in preventing the progression of the disease, so that it may help prevent you from getting very sick. Then he was started on something called remdesivir. This is a drug that's an antiviral. And the thought is that this would slow the progression of a virus replicating and help him to recover more quickly. And then when he had problems with his breathing, they decided to add something called dexamethasone, which is a steroid. And this has been shown to be helpful in patients that are requiring oxygen to prevent from getting very sick or die.
You mentioned remdesivir. That's one of the drugs the president is receiving, and that drug was initially developed to treat Ebola, and now it's helping to reduce recovery time of patients with COVID-19. You actually published an editorial recently in JAMA about this drug and criticized the lack of transparency and how it was being distributed throughout all the states. Tell me about that.
You know, remdesivir was the first drug to really be shown to speed recovery of COVID-19. So clearly, people would want access to it. Particularly very early on, there wasn't enough drug for where it was needed. This became even worse over the summer, where the government was distributing the drug to different parts of the country based on historical data of how many cases they had. The challenge with this is it created a lack of alignment, where you had places like Illinois that had plenty of drug because the case numbers were going down, but places like Florida, Texas, and Arizona that hadn't gotten as much drug and were running short, and in fact, in some places, running out of the drug. The reason why I think this is really important is that the government was totally not transparent in how they were making the decisions about distributing that, and at least initially wasn't giving a lot of clear data to the public about where the drug was being distributed. While that's improved, it's a harbinger of concern because we're going to be in a very similar situation when the COVID-19 vaccines initially become available. There won't be enough for every person that wants it, and there'll be a control of its distribution by the government. And again, I think people are much more comfortable recognizing if there's a shortage, if they understand how that very needed but limited product is being distributed.
You are also involved in clinical trials on both COVID-19 and influenza that could offer some new vaccines or treatments. Please share the details of the projects that are taking place.
Here at Northwestern, and I'll kind of talk about what all we are doing, is really covering kind of soup to nuts when it comes to research related to COVID-19. We've got a number of groups that are studying what makes people so sick. The pulmonary group has really made some sentinel observations about where the virus replicates in the lung tissue and what cells are important in triggering inflammation. This is critically important because it'll refine how we treat patients that are very sick with COVID-19. We and others have been looking at antibody titers in patients and what are predictors of high levels and how long they'll be sustained. This will be helpful as we start thinking about vaccines and helping individuals that have had COVID-19 know how long after the infection they're protected. We've been involved with a number of different drugs that have been studied for COVID-19. As I mentioned before, I'm the chair of the Data Safety Monitoring Board for the NIH trials that included the study that led to the emergency use authorization of remdesivir. The ID group is participating in those studies as well, so patients can participate in that. We had one of the largest and truly first study in which all patients at every Northwestern medicine hospital had access to convalescent plasma and enrolled nearly 160 patients throughout the entire healthcare system, giving them access to a potentially beneficial therapeutic. We have now a number of other studies funded by NIH and individual companies that are looking at things like monoclonal antibodies, immune enhancers, and modulators that should improve the clinical course of disease. And we've recently launched studies of COVID-19 vaccines here at Northwestern, again, with the goal of hoping to keep people healthy.
You've also adapted a current project studying influenza to instead collect blood samples from patients with COVID-19. How did you go about converting that project, and what have you been learning?
Having studies in place that you can modulate to focus on an emerging pathogen is critically important. And if we look at things even as big as the recovery trial from the UK that's led us to recognize that dexamethasone is a useful therapy, or the studies that we've been doing here, the study that the pulmonology group called the SCRIPT study really was a study looking at pneumonia in patients in the ICU that they pivoted to allow for enrollment and understanding of COVID-19. And then we had a study that looked at sequencing flu and RSV viruses in patients that were admitted to the hospital that we quickly transformed to allow us to collect samples, blood, and data from patients that had COVID-19. And from that, we've identified a number of different things. We've identified that at least early on, there was a unique clade of the virus that was more common here in Chicago than other parts of the country. We have learned that the viral load truly does correlate well with the clinical disease. And now that we've been studying convalescent plasma, from these patients that have recovered, we're starting to understand that antibody titers in the cells that make those antibodies are much more frequent in patients that have very severe disease than in patients with very mild disease not requiring hospitalization.
So will we be expecting some papers on some of those findings soon?
Yeah, so we have a couple of papers that are in the preprint press, medRxiv and bioRxiv, and then have several other papers that are undergoing late stages of review.
I want to shift gears a little bit to talk about influenza and COVID-19. How deadly is the flu season typically, and how do we prepare for this double whammy of the COVID-19 pandemic and flu season?
There is the potential of some significant challenges in the months ahead. The influenza on an annual basis really is an important driver for clinic visits, hospitalizations, and deaths. In an average year, there's tens of millions of extra clinic visits due to patients with flu or with complications of the flu. There are nearly 250,000 excess hospitalizations and about 35,000 excess deaths. And you can imagine if we were to add all of that to the healthcare system that's also burdened with COVID-19, it really could spell real challenges for the ability of the healthcare system to provide excellent care for our patients. Thankfully, many of the things that we do to prevent COVID-19 are also helpful for preventing the spread of flu and other respiratory viruses. And if you look at what happened in the Southern Hemisphere, like Australia, New Zealand, and South America, their summer is our winter. So they just finished their flu season, and they had some of the lowest number of cases of flu since we've been recording the number of cases. Additionally, there's a big effort to get people their flu shots. And if you haven't had your flu shot, now's the perfect time to see your doctor, go to your local Walgreens or CVS, and get your shot. This is the best way to prevent the flu, and maybe a way not only to prevent you from getting sick, but also it's hard to differentiate flu from COVID-19, and being protected against one will help you in that if you had the flu and didn't get the flu shot, you'll be nervous that you have COVID-19, whereas if you got the flu shot, hopefully that prevents you from getting it in the first place, so you don't have that added stress.
Is it possible to be infected with both COVID-19 and the flu at the same time?
It is possible to get infected with both the flu and COVID-19 at the same time. And in the run-up to the initial cases, there were clear examples of this being the case. And if you have them both, you can get more sick. The good news is it's relatively infrequent, and having either of the infections for a very short period of time makes you less likely to get infected with other viruses. And so that all contributes to a lower rate of co-infection. Unfortunately, if you're unlucky enough to get infected at or around the same time, it could mean a very severe illness.
And you mentioned it can be difficult to differentiate flu symptoms from COVID-19 symptoms, right?
Yeah, it's quite challenging to know if you have a cold, a flu, or COVID-19. There are some subtle differences between the two, but particularly early on with any respiratory illness, they can be indistinguishable. Additionally, even classic symptoms, people have heard about losing taste or smell, may not be unique to COVID-19 and could be related to other viruses. Additionally, feeling achy, feeling kind of run down and having respiratory symptoms. This is something who's ever had a cold or a flu has probably experienced and realizes that it may not be unique to COVID-19.
Well, we hope we can trend the way of Australia in those countries, and maybe with the mask wearing, frequent hand washing, those numbers will be lower, and there won't be so many people trying to differentiate what's happening with their symptoms.
The only way to really differentiate is to get tested. And again, this is why it's really important to get those flu shots so that we can get as few people that have other infections to drive patients into the clinic.
You recently published results of a study in the Lancet Infectious Diseases that found patients with influenza who were at risk of complications, they actually recovered quickly after early treatment with this newer influenza antiviral drug. Tell me about this drug. This seems like really good news. Tell me what you found.
The drug in question, something called baloxavir, is a medicine that's very different from the medicines we've used historically to treat flu. Those drugs basically prevent the flu from being released from the cell after the cell is infected, whereas baloxavir blocks the replication of the virus within the cell itself. Because of that, it can really drop the viral load very quickly. This study was kind of unique in that by luck, not by design, we enrolled the patients in a year where about half the people had influenza A and half the people had influenza B. And what we were able to find is that the new drug, baloxavir, was very similar to oseltamivir for patients with influenza A, but was definitely better in speeding their recovery in patients with influenza B than the current standard of care, which is oseltamivir. Importantly, this study was designed to look at patients at high risk of complications and showed that any treatment, either baloxavir or oseltamivir, was associated with fewer infectious complications and less need of antibiotics than patients that had received placebo. And so really, because of that, it really opens up our armamentarium to add a new medication for the treatment of influenza. There's a lot of potential benefits of this new drug. It's taken as a single dose. So you just take it once and you're done with the medication, as opposed to the currently available therapies, which takes 5 to 10 days worth of therapy to get you feeling better. Additionally, because the viral load or the amount of virus in your body comes down quicker, there's some thought that it may be better for you and you may transmit the infection to fewer people, but studies to confirm that are ongoing.
You said there's still some studies ongoing. When could this possibly be part of standard care for these folks who are at higher risk with influenza?
Yeah, so it's currently FDA approved for treatment of patients that have what we call acute uncomplicated influenza, which means that they're not sick enough to require the hospital. So it can be used in those patients 12 and older. There is a study that's looking at it in addition to oseltamivir for hospitalized patients, and we're very eager to see if it provided any additional benefit to patients with the combination compared to single drug therapy.
Any final words of advice for all of us as we now head into October and all these prime months for influenza and the ongoing COVID-19 pandemic?
I think the most important thing, and again, I think we have seen this with all the news that has been going on recently, that while people are tired, it's 7 months into the pandemic, and people want to go back to normal. We're just not quite there yet. You still need to wear a mask whenever you're outside of your own personal home, personal car, or your own office, because even if you're walking along the street by yourself, you never know when someone's going to come around the corner and come within 6 feet of you. You need to try to maintain that distance of at least 6 feet at all times. And if you're sick, stay home. Don't infect other individuals. The other thing that you can do is make sure that you get your flu shot. Now's the perfect time to get it before there's a lot of flu out there and the COVID numbers here in the city are low. Additionally, as we've learned, what we understand and how we give advice has changed over time. And so it's really important that you pay attention to the news, and particularly reliable sources like the CDC for advice on how to keep yourself safe and healthy, both for the flu season and the emerging challenges that we'll have in the months ahead with COVID-19.
That's all very good advice, and I know you will be extremely busy as we continue here in 2020, but I really hope you'll be able to take some time off in 2021.
Yeah, I think everyone's looking forward to getting us closer back to normal. It's still going to be a little while, even if we get a vaccine approved here in the near future. It's going to take several months before we get everyone vaccinated, but I'm hopeful that by summertime at least, hopefully we're getting closer to normal.
Well, thank you so much for being on the show today. We really appreciate it.
It was an honor to be here, and thanks for having me on.
For medical professionals who listen to this episode, be sure to go to our website to claim continuing medical education credit. Head to feinberg.northwestern.edu and search CME. We encourage all of our listeners to subscribe to the podcast on Apple Podcasts or wherever you download your shows. And if you could, rate and review us too.